One. We are live now.
Okay, good evening, everybody. Welcome to this evening's webinar. After a gap for Puja and last week. And today we have Dr. Arvind Gupta, who's going to talk to us about biologics. I think, as we're all aware of, there's been a lot of controversy as well as enthusiasm over the use of biologics in orthopedic surgery. Many of the studies are still not fully validated in terms of how well they've been done and to the conclusions. So I think, but however, there's a lot of promise in the use of biologics in orthopedic surgery. And today we have Dr. Arvind Prasad Gupta, who's in charge of sports surgery in Paras Hospital, who's going to talk to us about the use of biologics here. Okay, over to you, Arvind.
Thank you, sir. Thank you very much for the opportunity. So today I'll discuss about the orthobiologics. More I'll focus on use of orthobiologics in rotator cuff. Though we will discuss a little bit about the everything, but my more focus will be on this use in rotator cuff only. So biological approach to treat orthopedic injury seeks to improve by clinical outcome by promoting the tissue regeneration and the healing. And these approaches can be used in isolation or as an augment to the surgical intervention. So a little bit about the history of this use of biologics. It is in the 1867, the Julius F. Cohnhims, who identified that fibroblasts help in the healing process. And after that, almost after 100 years, there was identification of the clonal osteogenic cells by Dr. Alexander. And this is the 1991, it was the term that is the mesenchymal stem cells. This term was first coined by Dr. Arnold Kaplan. And after that, there is a lot of research over this mesenchymal stem cells, particularly in between 2000 to 2007. And the isolation of the mesenchymal stem cells started from the bone, adipose tissue, heart, placenta, recently umbilical cord, skin, lungs, all over the places. And in 2006, the mesenchymal stem cell definition was proposed and by the International Society of the Cellular Therapy. Again, benchmark year of 2008 and 2009, in which the perivascular origin of the mesenchymal stem cells was identified in form of pericytes and adventinocytes. 2017, minimal reporting standard for the clinical study using the mesenchymal stem cells, because the use of mesenchymal cells, just like sir said, how it's prepared, how it's used. So this is the minimal reporting standard was coined, that is the MIBO. And now in 2021, almost more than 1,000 clinical trial about the mesenchymal stem cells is already completed or going on. So now I'll discuss the current evidence on the use of biologics for augmentation of the primary cuff repair. Usually cuff get torn, and ideally it should get repaired to its footprint, and the healing should be enthesis regeneration, like the tendon get healed to the bone with the help of mineralized fibrous cartilage. But in most of the times, this tendon get heals to the bone by reactive scar, and there is failure to the mineralized fibrous cartilage. So despite of the advancement in the treatment, in the technique, in the suture anchor about the treatment of the cuff, failure rate is still vary in between 10 to 90%. And because of so much of the failure rate of the cuff after the repair, the lot of focus on the research to augment the healing of the cuff to the bone. And the most studied thing is the platelets-rich plasma. This is because the lot of growth factor in the platelets-rich plasma that involved in the healing process. And it was the Boswell who outlined that this PRP having both cellular component and the chemical signals. And in this cellular components, if there is increased platelets in the PRP, this PRP will have anabolic signals. And if PRP is rich in leukocytes, then this will have the catabolic signals. Usually PRP divided into the 4 types, depending upon the concentration of the cells, that is the leukocytes and the platelets, and the amount of the fibrin network, whether it's less or more. So if leukocytes is high in the PRP, that is the leukocytes rich PRP, leukocytes poor PRP. If there is rich in the fibrin, then the leukocytes is also rich, then leukocytes rich, platelets rich fibrin. And maybe last one is the pure platelets rich fibrin. So whether it's plasma or fibrin, or whether it's leukocytes or platelets. Another study says the different tissue needs different amount of concentration of platelets in the PRP to have its optimal tissue response. Just like the soft tissue wound needs lesser amount of platelets to have better outcome in comparison to the joint, that needs the higher amount of platelets concentration in the PRP. About the literature, what PRP says in the healing of the cuff, it is the systemic review in 2012 says there is no difference in re-tear rate and the patient outcome. Similar study by the Worth in 2014. This was the meta-analysis. But the deeper study of the Worth did find that on subgroup analysis, when tear were greater than 3 centimeter, the PRP treated group shows the significant decrease in the re-tear rate in the cuff, particularly in the double row construct. Another study in 2014 and 15 says the leukocytes poor PRP will have lower re-tear rate compared to the regular PRP. Now the CAI shows did the study of the 5 randomized control trial, and they concluded that the overall there is no impact of the PRP on the clinical outcomes. But again, subgroup analysis of the same study says PRP decreases the re-tear rate in a small to medium-sized tear. That was different from the Worth study, who says it was the large tear in which the PRP will decrease the re-tear rate. Recently published in 2015 one. Hurley recently in AGSM 2019 says there is significant higher healing rate in medium, a small medium and medium to large thickness tear with improvement in the constant score and the VAS score. Again, it was a meta-analysis of randomized control trial. Now the systemic review of the meta-analysis. So 7 different meta-analysis systemic review was done by the Salzman and says there is no clinical benefit in terms of the functional outcome. In the same study says if you are using the solid PRP in comparison to the liquid PRP, the improve will be better. And again, if PRP get placed directly at the bone tendon interface, will have better outcome than the PRP injected over the tendon, particularly in double row construct. And again, systemic review and the meta-analysis in 2020 recent paper says the aesthetically significant improve in their short-term and the long-term constant. It reduces the VAS score in short term And patient, those who are receiving the gel preparation have a statistically significant better constant score in comparison to the non-gel preparation. And regardless of the patient who were treated with the leukocytes poor or platelets poor PRP, there was a significant reduction in the retear rate. So author neither promoting nor discouraging the use of the PRP. About the timing, most of the investigator had delivered the PRP at the time of surgery or end of the procedure. But the SNOs propose a delayed application may be beneficial. However, they find there is no significant improvement in the healing or functional outcome following an ultrasound-guided PRP injection as day 14 following rotator cuff repair. But on ultrasound study later on, they demonstrated that there was reduction in the fatty infiltration as comparison to the control group. Recently published in AGSM 2021. So overall consensus of the use of PRP in rotator cuff, there is no benefit in functional outcome. However, PRP may be advantageous in prevention of the retear rate. So next is the stem cell based augmentation. The concept here is to target the pluripotent stem cell directly at the rotator cuff repair site so that the cell get differentiated into the tenocytes. And there is a lot of preparation about the stem cell based augmentation that start with the mesenchymal stem cells, then the bone marrow aspirate concentration, the bone marrow stimulation, that is the macrofracture. Recently, the adipose-driven stem cell get derived from the adipose tissue. Then again, the mesenchymal stem cells get driven from the umbilical cord blood. And again, the bursa, that is the subacromial bursa-driven cells. So let's see, start from the mesenchymal stem cells. The literature in 2020 says the animal model use of mesenchymal stem cells says there is a statistically significant improvement in the ultimate load to failure, the repair site stiffness, bone mineral density even get improved with mesenchymal stem cells, and there is a lot of fibrous cartilage formation at the healing site. But this enhanced healing potential have so far failed to demonstrate the benefit on the clinical basis. Next is the bone marrow aspirate concentration, basically bone marrow taken from the either iliac crease or proximal part of the tibia. And this get concentrated and in around 15 minutes it's ready to use. Initially it was used like that. Recently there is a lot of modification both in the this machine also that purified also and in centrifuge also. And again this bone marrow aspirate get cultured also. So every steps is having every types of preparation of bone marrow having advantage and disadvantage. Like initially the centrifuge bone marrow aspirates was used, having easy to isolate and immediate can be given to the patient. And there is a lot of disadvantage also because of efficacy get reduced because it's not the pure 100% pure. Character is not very so specified and associated with lot of debris also. Then the next is the cultured enriched, having again potential for the ultimate yield and well characterized. But only thing, culture usually take 2 to 4 weeks. So having disadvantage of that, it reduces the potential to get differentiated into the tissues. The recent is the purified one, fluorescent activated cell shortening. In which the purified, these cells get reduced. Only thing, it's very expensive. And still there is regulatory things has to be finalized. In the literature, use of bone marrow aspirate concentration, if you see in the rotator cuff, at the 6-month retear rate, the BMAC group says there is 0% retear rate. Whereas in the control group, it was 67%, published by the Hernigo. And the 10-year post-op surgery healing rate in BMAC group was almost 87% compared to 44% in the control group. Similar study by the Elira Gomez, and he support the concept of this hernigo. She uses this in mini open rotator cuff repair. So in summary about the bone marrow aspirate concentrate, limited scientific evidence which does not allow for a strong conclusion in regards to use of BMAC in rotator cuff surgery. Next is the bone marrow stimulation, microfracture, very commonly done by arthroscopy surgeon for rotator cuff repair or any injury, cartilaginous injury in the knee while doing ACL. So it's the preclinical and clinical study has suggested that the microfracture of the footprint during the repair site for the rotator cuff result in lot of release of bone marrow at the repair site. Very well popularized by the Snyder for the rotator cuff repair, and this help in the healing and reduces the re-tear rate. First by the Snyder, then the Sun, recently in 2020. But in 2019, the meta-analysis says there is no statistical difference. However, the significant reduction in the re-tear rate in the bone marrow stimulation group in comparison to the control group. The next cells derived is from the adipose derived stem cells. It was the Kim in 2017 who published the first clinical result, and there was no difference in terms of the functional outcome. However, the structural integrity of the tendon, as indicated by MRI, proved to be significantly better in adipose-derived stem cells in comparison to the control groups. Next is the umbilical cord blood-driven stem cells. So basically, all the published data are on animal models only. And all the studies says this healing of the cuff is higher with high concentration of the type 1 collagen. But there is further investigation is needed to determine the utility of the umbilical cord blood driving mesenchymal stem cells. The subacromial bursa driven stem cells, again, stem cell get driven from the subacromial bursa. It was the Morikoba who conducted in vitro study in effort to compare the subacromial bursa driven stem cells in comparison to the bone marrow stimulation cells, and found that this subacromial derived stem cells having significantly increased in differentiation ability and the gene expression over the time compared to the bone marrow stimulation, bone marrow concentration product. And similar data was further substantiated by the work of two other researchers. But again, because of limited in vivo and human trial, still subacromial bursa driven cells need to be more research and more published. And there is lot of scaffolding device for the cuff part, that is the biological, maybe synthetic, extracellular matrix. Recently, the nanomaterial scaffold, maybe hydrogel scaffold, again all having limited evidence. The future direction about the gene therapy and the gene editing, this has been hypothesized as a possible target in helping to improve the biologic activity of the progenitor cell lineages. The exosome of the mesenchymal stem cells have recently been extracted, and the studies as a possible adjunct. The use of augmented suture and anchor should also be continued to be explored. And then there is nanotechnology has recently explored as a possible adjuvant in ending the rotator cuff repair success. So the pro-regenerative characteristic of the growth factor and the regenerative cell types hold the great promise for musculoskeletal tissue engineering. The early favorable results from in vitro work are now being supported by level 1 study in limited number of clinical settings. Irrespective of the setting, clinical use should be based on a comprehensive understanding of injury, what is the use of environment, and the biological therapy where it is going to be delivered. And we have organized the first Patna hip orthoplasty course. John Mukhopadhaya sir is the chairperson, organizing chairperson, and myself is the organizing secretary. You all are invited on 19th and 20th of November of 2020 for this first Patna hip orthoplasty course. Thank you.
Okay, thank you, Arvind. That was very instructive and useful. Is my video visible? Okay.
Yes, sir.
Wasn't sure.
Yes,
So
sir.
we'll go on to the questions to see. So where the biggest issue at the moment is, where do we stand in terms of how predictable and useful the response is to any of this, and how does it compare with placebos, etc.?
So as literature says, there is lot of variation in the preparation part, lot of variation in the concentration part. There is lot of variation in the timing part. How much concentration we should put. Recent literature says is the concentration of the platelets vary in different tissue for its optimal result. It's not like if you are giving them highest concentration of platelets, that will work in soft tissue injury also, or in bony injury also. So this is the difference. Still a lot of research over that going on, and some literature comes with the exact concentration what should be delivered for different type of tissue, for the joint degeneration, for tendon degeneration, for bony healing. And again, the preparation part, different company is having different type of preparation about this. And literature also varies. Some says if platelets, this leukocytes is poor, the healing potential will be better. But another side literature says there is no difference between whether it's leukocytes poor or leukocytes rich. So still this very clear options uses is still not available for us. But as vitro study is saying that it's having result, and at the same time, the level 1 study, lot of level 1 study in the literature saying that we can use this PRP.
Yeah, I know this is going to be a while before it's clear, but definitely there is promise in use, and something we need to keep our mind open about. Okay.
Yes.
So questions?
Yes, sir. So Sachin has asked about orthobiologics uses other than rotator cuff injuries.
So basically, most commonly used orthobiologics is in this all the tendon injury or inciopathy, like the tennis elbow, plantar fasciitis. Lot of the use in healing of they give promise about the healing of the partial tear of the ACL, also partial tear of rotator cuff that we have seen, and all other tendon injury also, like this bicipital tendonitis, lot of things getting injected. So all the tendon injury can be deal with this biologics, particularly the platelet-rich plasma. At the same time, the this pathological condition in form of tennis elbow also, the plantar fasciitis also. So this can be used.
So about the rotator cuff injuries, sir, which one is more useful? Is it platelet-rich plasma or platelet-poor one? Because in AOS guidelines, they are not very clear about it. Actually, the role is very limited according to them.
Yeah, literature says it should be the leukocytes poor. the concentration of leukocytes should not be high. And definitely this leukocytes poor platelets rich plasma.
Okay, sir. And so, what about in osteoarthritis, sir?
Yeah, definitely lot of research is going on about the use of this osteoarthritis. In fact, a paper from India, Chandigarh, was the use of this PRP for osteoarthritis was published very long time ago in 2014 only. But still, the conclusive data is not available to us. Whatever the data is, mostly is for tendon injury, particularly the rotator cuff. We have a lot of research and all this tennis elbow, plantar fasciitis.
May I know about in your practice, sir, how commonly you use these orthobiologics and where usually?
So I did a study on at a sports injury center about the use of this resistant type of tennis elbow, particularly mostly where the military personnel, the CSFI, CSFI and
Yes.
BSF. Yeah. So in that they were already taken 2-3 injections of steroid or some sort of another treatment, and there was no response of that. So this study was on 30%. So we started this PRP use in between 2011 to 2013. So what we does there, we have facility of lab in the basement only. So immediately taking after 10 ml of the blood, I went to usually go to the lab, and there I asked the person to transfuse at this 10 minutes at 1000 RPM. And
It's
after that,
centrifugation, yes.
yeah, centrifuge. So 6 ml most of the time they gave to us 4 to 6, and usually that get injected. That injection part is very painful, almost for 12 hours. It's very difficult time for the patient. But it was very surprising to see almost 90% of the patient don't come for second injection or any type of further analgesic after 2 months. That was very surprising. Still, I doing at this paras also, but very less frequently, almost 3 to 4 months, once a 3 to 4 months. And the process is the same.
So interestingly, I have not injected a tennis elbow for more than 15 years.
Oh, great.
Or 10, or maybe it's definitely 10 years. Yeah. So I just give them exercises. It's interesting that it's the shoulder muscles which go weak, and the stress comes on the elbow, and they end up with these problems. So almost all of them, we advise exercises to build up the shoulder muscles, especially the infraspinatus and the trapezius. And I haven't actually honestly injected. I mean, I know there'll be a few which will not be respond as well, but majority of them seem to have some benefit, and we've not had to actually inject any of them. So I think we really need to look at tennis elbow a little more carefully in terms of what the cause is, rather than just treat it by injections of various sorts.
Absolutely right, sir.
And we haven't operated on one for, I don't know, for such a long time.
So one more confusion usually and it has, but it is only for partial tear or tendinopathy, not for if the tear is more than, I think, 30% or like that.
So literature says they have used both in partial tear and the complete tear also. So, and after most of this literature that I have discussed was after the repair of the rotator cuff. So they have used in all partial tear, complete tear, and after surgery also, because healing of this enthesis regeneration is very poor with the rotator cuff because of the biological problem and blood supply and all these. So concept was to augment the repair part, but still there is no very clear opinion about the uses. But clinical outcome, they have mostly compared with the clinical outcome come with, and the deeper study they did, and they found that the healing rate is better At the same time, a strength of the cuff was also better. Fatty degeneration was also less. But the clinical outcome is not very statistically significant.
So, one more question asked by Dr. Narayan is about its role in plantar fasciitis. Although I want to know how you treat the plantar fasciitis, sir, and what is the indication if you are using any orthobiologics?
So mostly plantar fasciitis get treated with a stretching exercise only, and the physiotherapy modality in form of ESW that we have.
So again, for plantar fasciitis, also try to avoid injections as far as possible. Stretching plantar fascia and TS stretching, things like contrast baths, etc., help, silicone heel cushions, and most of them are self-limiting. Every now and then you'll get a recalcitrant problem where you can try ultrasonic shockwave therapy. So that's another option that you have for plantar fasciitis as well as TA tendinosis, with again varied results. I would say not all of them successful, but some of the recalcitrant ones do respond to shockwave therapy.
So, do we have any role? Sorry, sir. So,
Yeah.
do we have any role of vitamin D in plantar fasciitis? That because in
Vitamin D.
yes, sir. Yes, sir. For heel pain, sir, usually we are
Well,
using
the problem is
the
vitamin D is sort of is one of the ubiquitous things where everything you can say it's because of deficiency. It's important that your levels, or you have adequate vitamin D in your diet and adequate levels in your blood for many things in the body, but specifically for arthritis, I'm not sure if there's any very strong evidence for that. Arvind, any?
No idea, sir. No idea about the use of vitamin D in plantar fasciitis. But one question to you: have you ever surgically treated this plantar fasciitis?
The answer is no. Well, we've done plantar fascia releases for some things, but it's not pure plantar fasciitis. I think we've done it for.
So treatment is basically, if surgery has to be done, that is the release of plantar fascia.
Yeah, we'll have to do that if we have to. And debriding sometimes. So sometimes the fact that someone's had injections may be the reason why they need surgery to debride it and things like that.
So one more thing, sir, which is slightly related to this topic is about the needling, that hollow needle. That is it. What is your experience about this one, sir, and what are the indications? Because there are many papers we have seen.
Sir,
Sorry, what did you say?
treatment of all these
About the
types of
needling, sir.
Needling.
needle release.
So that would again be, I guess, related to releasing the fibers. Yeah. Sorry, is that what it's due to? No, Janki, what are you trying to say?
Sir, because sir, in few papers they have mentioned about that hollow needle. They used to put the needles in a recent few of the societies. They have mentioned about that one, like when they used to put hollow needle and like for the tennis elbow.
No, but hollow needle and do what with it?
Puncture,
Sir,
multiple puncture.
Multiple puncture.
So that will be in a way releasing the tight tissue there. Okay, it's like some people actually do a TA lengthening with just a needle, multiple needle, this thing to release the TA rather than cut it with the knife. Okay, so that is one option I guess they might be trying. But again, it's to look at what the evidence is and then decide on that.
Oh, I think we have covered most of the things. Yeah.
Okay,
So,
great. So thank you very much.
yeah.
And what is our topic for next week?
So that we have to decide, sir. We have not yet decided.
Okay, great. So thank you very much, and see you next week. Whatever.
Thank you.
Thank you so much, sir.
Okay, bye.
Thank you, sir.
Thank you, sir.
Sure, bye.